I'm a Canadian radiologist practicing in Toronto since year 2000. The question of today's talk is patient shielding recommended for X-rays, fluoroscopy, CT scanning, and/or mammography? I'll show some examples of patient shielding options. I'll talk about the intended benefits of patient shielding, which we started using over 70 years ago. We'll learn about the potential harm. We'll look at references of current recommendations. I'll also answer some frequently asked questions while providing a pros and cons analysis. With its high atomic number and high density, lead has been the most commonly used material in patient shielding. Common examples include thyroid shield and lead collar around the neck, gonadal shield placed over the pelvis, half apron, or some places call it a blocker, and some materials that you can actually put on like regular clothing. It may be a separate vest and skirt combination or a one-piece. The idea of patient shielding was first introduced in the 1950s when we had to be very mindful about the effect of radiation deduced from fruit fly experiments. In the last 70 plus years, thanks to technological advancement, the amount of radiation involved in medical imaging has significantly decreased. Look at this blue bar chart prepared by the Canadian Association of Medical Radiation Technologists. The amount of radiation exposure to the pelvis has decreased from year 1951 to year 2020 by 20 to 25 times. Also, thanks to research, we have learned that the human body is actually less sensitive to radiation used in medical imaging than previously estimated. In particular, the effects on our gonads and the fetus are not worrisome at all. The main intended benefit of shielding is obviously to reduce radiation. But can all types of radiation be reduced? When the primary beam of X-rays strikes a patient, there will be scattered radiation in all directions. And when a pregnant woman undergoes chest X-rays or chest CT, while the primary beam targets the chest, there will be some external scattered radiation towards the abdomen and the fetus. By wearing a lead apron, this can be reduced or stopped. However, there will still be internal scattered radiation going from the chest towards the abdomen and the fetus. In other words, shielding cannot reduce internal scattered radiation. We should recognize that the intended benefits of patient shielding have been decreasing in the last 70 plus years, to the point someone may use the word negligible. Today, the only real significant benefit may be only psychological. Is there any potential harm using patient shielding? Yes. Most importantly, it may obscure anatomy and hide abnormalities, leading to a repeat study. For example, when taking chest X-rays, if we allow this patient to wear a thyroid shield, there will be a white triangular area blocking the neck region, obscuring visualization of the small basketball. In actual scenario, the small basketball may correspond to a swallowed coin in a child. There may be abnormal gas or fractures in the neck region, or sometimes we may need to assess the positioning of a tube. If we don't see the area, we're going to need to repeat the X-rays. Similarly, if we allow the second patient to use a half apron, the white rectangular area in the lower body is going to obscure where the small basketball is. In this case, the small basketball may correspond to a metallic foreign body. There may be abnormal bowel gas pattern or fractures in the region, or sometimes we may need to assess the positioning of a tube. Again, if we don't see the area well, we have to repeat the X-rays. The original intent of using patient shielding is to reduce radiation dose, but if we have to repeat the study, it defeats the purpose, because we're going to at least double the dose in this case. Most of the new equipment nowadays has automatic exposure control system, where we can try to achieve great image quality with optimal radiation dose regardless of patient body habitus. However, if patient shielding is also used, there's a potential of misleading this AEC system into delivering a higher radiation dose. And this is true for both X-rays and CT studies. We should also mention that patient shielding actually indirectly increases a small amount of secondary internal scattered radiation. Let's look at some references together. It seems to have all started in April 2019
when the American Association of Physicists in Medicine made the position statement about patient gonadal and fetal shielding should be discontinued as routine practice. Then in March 2020, the British Institute of Radiology also talked about fluoroscopy and mammography and specified that breast and thyroid shielding are no longer recommended. In May 2021, our Canadian Association of Radiologists and the Canadian Association of Medical Radiation Technologists made similar position statements about discontinuing the use of gonadal and fetal shielding for patients. Then in August 2021, the International Society of Radiographers and Radiological Technologists talked about not just X-rays but also CT, and they specified that thyroid, eye, and breast shielding are also not necessary.
Scanning multiple Canadian cities, I noticed that in Vancouver, British Columbia, there were changes as early as in July 2022. In Alberta, we saw changes in Calgary as well as in Edmonton already. Back in Toronto, our highly respectable Hospital for Sick Children has an educational poster. I magnified the images to better show the gonadal shield can obscure part of the pelvic bones, and in case the patient has a lytic bony lesion, in this case in the left pubis, it will not be detectable. So the teaching point is that even for children taking X-rays, we should not use patient shielding. In early 2024, Hamilton, Ontario has similar poster and changes effected. And in William Osler Health System, we had this new policy beginning in December 2024 in Brampton and Etobicoke. And in Markham, Ontario, the new policy just became effective in early 2025. Let's go through some common questions which may also be on your mind at this moment. Question number 1. Patient shielding was provided the last time I had X-rays. Why changed? The simple answer would be cons more than pros. In the last 70 plus years, the intended benefits of patient shielding have been decreasing to the point of becoming negligible, while the potential harm is obvious, obscuring areas to be assessed, leading to repeat of study, misleading the AEC system, leading to higher radiation dose, and indirectly increasing the amount of secondary internal scattered radiation. Cons more than pros, the need to change is obvious. Question number 2. Any special arrangements for kids and pregnant patients? Not necessary, because all the X-ray studies are supposed to be done with the Alera principle in mind. As long as the patient's doctor deems the X-rays or even CT study medically warranted, then we always try to do it using the lowest achievable radiation dose. We do not need to consider using any patient shielding. Question number 3. Why lead shielding is still worn by staff members? The simple answer is pros more than cons. Unlike an average patient who may take X-rays just once a year or at most a few times a year, staff members work longer hours regularly and repeatedly in an environment with scattered radiation. We need to put on lead shielding to minimize the effect from radiation, and we don't have to worry about obscuring any imaging parts nor misleading the AEC system. Those of us who work in the radiology department are given 2 dosimeters, one to be worn outside and one under lead shielding, to be submitted every 3 months to make sure we are not overexposed. Question number 4. Why lead shielding is still recommended for accompanying family members? The simple answer is pros more than cons. In most circumstances, family members actually are not needed in the room with radiation. In some cases, family members may just stand behind a protective screen and will be okay. Only in very special circumstances, a particular family member may be needed to stand right beside the patient, and if so, we'll give them thyroid shield and one-piece lead shielding to get protection from scattered radiation.
Question number 5. If I'm too anxious, can patient shielding be provided as an exception?
Possibly for psychological reason, but only if it does not obscure anatomy nor interfere with the automatic exposure control system. Question number 6, our last one. Is thyroid shield necessary when taking mammograms? Absolutely not, because the radiation to the thyroid is extremely low during mammogram, and thyroid shield may distort image quality. Back in 2011, there was a Dr. Oz, a famous cardiovascular surgeon, who preached about the use of thyroid shield on his own TV show. Since then, his fans or someone else would repeat the same question every few years after. So please remember, thyroid shield is unnecessary during mammogram, and we should not spread any misinformation from anyone, including Dr. Oz. I've completed all the agenda items, and I hope you've learned the logical reasoning behind when and when not to use lead shielding. I started today's talk with a question. Is patient shielding recommended for X-rays, fluoroscopy, CT scanning, and/or mammography? Of course, no. Patient shielding is no longer recommended for medical imaging. If you find today's video useful, please like, comment, share, and subscribe. See you next time.